I have been blessed to have been in the industry for over 40 years, and I've worked with pretty much the entire age and service delivery continuum with respect to healthcare with the individual enrollee, patient, whatever, however you define them, as at the forefront of what I do. Um, I've worked in over 25 states, and I've worked with physical disability, with the physical health, behavioral health, and many, many special needs populations. I started my career as a med-surg nurse and worked in a hospital for over 14 years in a variety of roles. At night, I was the administrator while I was going to graduate school for my nurse practitioner certification. And after that, I worked employee health. I did strategic planning. I was over medical staff services. So I have a really good understanding of not only the healthcare system within the hospital, but also in the larger healthcare arena. What got me sort of in the direction I'm in is that the hospital I was working for was asked, it was a part of a large healthcare chain, and was asked to be a pilot site, the hospital in Maryland where I worked, and one in Texas. And I was asked to lead a team of 12 people from across the country in various different roles in healthcare to redesign healthcare delivery systems. So we had the opportunity of working with two McKinsey consultants. And basically, we spent 7 months on a project to stop unnecessary procedures, to shift accountability and responsibility to the right enrollee, in other words, a right person. So a nurse shouldn't be running to the pharmacy or discharging people in a wheelchair. They should be doing direct care and educating the consumer. And then to streamline activities, so many forms are required, and we were trying to look at ways to reduce that duplication and streamline the processes. So anyway, I did that for quite a while, and then when I completed that, I became a corporate consultant for a year, and then they decided to not do the program any longer. So I went to a think tank in Baltimore, University of Maryland, Baltimore County, and worked to help develop Maryland's Medicaid program, and helped write regulations, and also wrote the policy and procedure manual for Medicaid. So that then sent me on a new journey to KRA, in which I was asked to be the director of health and help establish a healthcare practice. At that time, KRA was very much a social science firm. We did a lot of event planning across federal agencies. And so they wanted to expand upon the healthcare aspects of things that we were already doing, like working with the Office of Women's Research, and we had the minority health clearinghouses. So anyway, I did that for a few years, and then decided that I wanted to go out on my own. So from year 2000 to the present, I've been working for myself. And the majority of that time has been spent in different states helping to improve services for individuals that are receiving services, whether they be in a waiver program, whether they're medically fragile, technology dependent, whether they have behavioral health issues. So anyway, I have been very much involved in evaluating children's mental health programs and federal waiver programs on all variety of the waivers that the federal government offers states. So that's kind of brought me to where I am with working with KRA. So for the last 25 years, I've been a consultant with KRA, assisting the Qlarant, the primary contract with the federal government for Medicaid managed care in Maryland. So I've been assisting Qlarant in evaluating the 9 managed care health plans in Maryland, and that's afforded me an awful lot of opportunity to see things improving over time. So anyway, that's that. I still use my clinical skills, but instead of assessing an individual as a nurse practitioner, I guess I'm evaluating large health systems and trying to make improvements systemically there. Medicaid started back in 1965 as a safety net for families and children and pregnant women who were basically impoverished. So it was establishing some parameters around low-income families. And over the last couple of decades, states have expanded Medicaid to include a lot of different special needs populations, disability populations, HIV, renal disease, I mean, any number of unique groups. And the whole focus has been to try to get more and more people, especially children, served so that they can have better health outcomes as they age. So it was once women and children, and now a lot of the healthcare services are for older adults as well. So Medicaid managed care is moving from just the acute care, chronic health diseases, to long-term care. Many states have moved in that direction to have Medicaid managed care for home and community-based services. So it ultimately has been an ongoing expansion and increasing the federal poverty limit so that more and more people can have access to care. So when I look at, as of effective January 1st of 2027, I think the health industry is going to be navigating one of the most significant changes in Medicaid that has occurred in the last 60 years. And that is the Trump administration's One Big Beautiful Bill Act, which was signed into law July 4th of 2025. What I have learned is that this new legislation is set to make about $1 trillion, and I mean $1 trillion in cuts to federal healthcare programs, both Medicare and Medicaid. So when you look at Medicaid specifically, states are looking at about $940 billion in program cuts, and that's very significant. What this means for states, managed care organizations, individual recipients is that beginning in 2027, there's going to be some specific requirements under the legislation that are unique, and actually I think will make us go backward in time with helping. I think it's going to decrease access to care, but let me just give you some specifics of the legislation. States get funding from the federal government, and it's a joint partnership between a state and the federal government for Medicaid. So some states get a match of 90% federal dollars to 10% state dollars, and those are typically, the more federal dollars go to those states that expanded Medicaid in the last 10 years. So that portion of Medicaid funding will be reduced, meaning less dollars are there for programs and services that address social determinants of health, like food, housing, transportation, and just community-based organizations may end up either terminating their services. Managed care organizations may in fact exit the healthcare market because of the restrictions placed. One of the changes is going to be a change in the eligibility redetermination process for Medicaid. States now are required to check Medicaid eligibility about every 12 months, once a year, and that has moved now to, it will be, states will have to redetermine an eligibility every 6 months instead of once a year. They will impose cost-sharing requirements for enrollees, $35 per service for those with incomes greater than the federal poverty limit. There will be bans on provider taxes. Providers can expect to have net revenue decline. And the importance of provider taxes is these are the dollars that the dollars that come from provider revenue over taxes is what is used to fund Medicaid programs. Medicaid payments for migrant services, migrant health workers in particular, including emergency room care, will be banned. And Another huge shift, which for your audience is an important one, is the requirements, Medicaid work requirements that are tied to eligibility. So these eligibility determinations will be tightened, and applicants will have to show verification of work, especially the 19 to 64 age group. This means to be eligible for Medicaid, you must show proof of work, 80 hours of what is called community engagement. And I think of community engagement as outreach to individuals to educate them on programs and services. In the context of this new law, community engagement means that the individual has either paid work, community service, or they're involved in some type of educational program. And so it's anticipated that 18.5 million people will have to prove they're working. This validation must occur like 1 month before a new applicant is trying to get Medicaid services, and then 1 month before each of the 6-month renewal periods. So you can imagine the challenges that states are faced with trying to navigate this timeliness requirement in such a short period of time. We're talking 6 months from now, and the actual details of this legislation probably won't come out till sometime in the summer. If the community engagement is not met, then individuals can't access health insurance in the marketplace. They will be subject to cost sharing, to paying for premiums for insurance. The other piece of this that's really important is that there are a lot of exemption categories, and I think it will be really important that information systems can capture these. For instance, children under 19, youth in foster care, people that are on both Medicaid, Medicare are exempt, blind and disabled, pregnant women, individuals with substance use disorder, people with disabling mental health conditions, physical, developmental, or intellectual disabilities are exempt. And the piece that I find really interesting is that there's another exemption for serious medical conditions, and that's sort of referred to as medical frailty. And I think it's going to be a real challenge for people to determine what means medical frailty, because we don't have any service codes, any codes that determine if someone's too sick to work. So I think how those individuals are identified is going to be a challenge for a variety of entities. And so, that's going to be changes to processes and workflows and information systems that will be really critical to make that happen. When you think about what we do, it's always important to sort of step back and say, what is the whole purpose of all these programs? And that's to help individuals have a healthy life and develop normally or within the parameters of the conditions that they're faced. And I think the service reductions will have a huge impact on people accessing care, and all of the administrative burden of these, more frequent eligibility determinations will be possibly a barrier to individuals even trying to access care. And what that means is that the more parameters or criteria you put on an individual to apply for services, to verify things, and to actually reach those individuals. I think insurance, there will be a lot of individuals who drop off of health insurance. More and more people will be using the emergency room for services. I think more chronic health conditions will be exacerbated, or new ones will develop because we don't have the services available for individuals. And I think care is going to be compromised if there are less community resources, especially those that help address racial and ethnic disparities in healthcare, which the states and health plans have done a really good job of late trying to address these racial disparities in healthcare, and also identify and assess for social determinants of health, which housing, food, shelter, housing, food, transportation, all of the services that tend to be affect one's ability to access care. So the other piece is that so many of workers in our country are immigrants that are trying to establish citizenship in our country, and this safety net's going to be removed for them, and it will certainly affect, again, some of the minority populations that are going to be restricted from from receiving Medicaid. So I think there's an awful lot of individual access to care issues that we need to face. And quite frankly, over the years I've worked with managed care organizations, access to preventive services and gaps in care is one of the most predominant issues that health plans try to address, and also trying to get provider networks up to speed to address the services that are needed in the community. So I think that's going to have a much more of a deleterious effect on these access to care issues. KRA-Qlarant is what is considered an external quality review organization. Every state that gets federal funding for Medicaid programs is required to have an independent external review of compliance to federal standards. And then you couple that with individual state standards. Every state's different in how they operate Medicaid, but each state has its own standards for how care should be delivered. And in addition to that are the contracts that managed care organizations have with states. So what the external quality review entity does is they follow a set of federal, what we call EQRO, External Quality Review Organization protocols. And those protocols provide information on what the federal government is looking for. What KRA does, we have 2 consultants for KRA that work directly with KRA-Qlarant, and I'm one of those, and the 2 of us have worked with KRA-Qlarant for over 25 years, especially in Maryland. So we've been able to look at the evolution of the health plans over time and see the significant positive changes that are made. So KRA works with KRA-Qlarant to try to identify how to write up standards of care, what we need to look at to address the intent of the federal standards. And that's one of the things I think KRA provides a lot of value, is that we look directly at the federal register. We look at the standards as they were written. We look at the state standards as they're written. We look at the contracts. What we try to do is look at what is the intent of this standard. A lot of times I've reviewed federal standards, and the requirements that the federal government has laid out in a compliance requirement doesn't necessarily meet what the legislation was. So we have to kind of interpret some of those things to help states understand why these standards were established in the first place. So we examine all of those regulations, and then once we have an understanding, and in Maryland in particular, KRA, Maryland has, most states have their managed care programs in contract form, the states and the managed care organizations. In Maryland, there's what's called the Code of Maryland Regulations. It's called COMAR. And in Maryland, the standards are not only written into contracts, but they're state law. So the MCOs have to follow these processes in the level of detail as they're written in the state legislation. So once we've conducted this baseline review, we don't need to do it again unless there's a change in regulation, or an addition to a regulation, a deletion of a regulation, an addition, added regulation. So and if there's a new managed care organization, there are currently 9 in Maryland. If there was a new one added, we may help the state do a readiness review of that managed care entity to ensure that they're actually ready to accept enrollees into Medicare managed care, Medicaid managed care. So there are like 6 different protocols that we have to examine or evaluate. They have to do with enrollee rights, with outreach, with all the MCO operational areas like care coordination, utilization management, credentialing, privacy practices, health information systems, and then there's a whole subpart on quality improvement and performance improvement, and another whole subpart on enrollee grievances, appeals, and service denials through the authorization process. So there's a wide range of things that we look at, and we make those assessments, and then we provide our findings to the state. And the one thing that we do not get involved with is finance. The insurance, Maryland Insurance Administration especially does reviews, as well as certified public accounting agencies look at finance. So we're not involved in any aspect of the financial decision making. But ultimately, our role is to say, based on all these federal and state requirements, does the health plan have policies and procedures in place that address those particular requirements? Do the plans implement those policies and procedures as written according to the requirements? And then I like to look at what methods are in place to assess the outcomes of those initiatives. So if there's certain things that are being implemented, you don't just keep implementing the same thing over and over if there's no positive outcome. You're trying to look at things that make a difference to the enrollee in the process. So KRA's role in this, I think, is quite significant. As a matter of fact, we are moving as of this summer. We're trying to fill a position with KRA to help within continuity of care, because one of the consultants is retiring, and I most likely will be in a few years. So we're trying to ensure that there's some continuity of this process there. And KRA's, has a real opportunity to really embrace some of these processes, I think, for ensuring quality in the health plans. I think one of the things that the KRA team brings to Qlarant and to the states is that we really approach the evaluation. We don't refer to it as auditing. The health plans call us auditors. I don't like that term because it implies this finite, I think of finance and auditing, whereas we're really evaluating processes, and we always use a strength-based approach. We're not punitive in any way, shape, or form. We can be extremely professionally objective in our evaluation, but we want to look at this as a collaborative relationship, because in essence, we're all in this to try to make things better for the enrollees that are receiving services. So if we, we want to ensure that it's not just a look at we're complying, we're looking at quality assurance and you're meeting the standard. We want to ensure that they understand a difference between quality assurance, process improvement, and continuous quality improvement. And all three of those things are different. So if there's not any sign of like systemic change for the better, then we make recommendations and we question. And I can give you an example on that. One of the things that we look at, and the first thing I look at with any health plan, is have they done a population analysis? And that's looking at demographics, looking at the geography, looking at prevalence of inpatient, emergency room, outpatient, pharmacy conditions. Do they know the population they're working with? And that's outside of what the federal government requires. So we know that the federal government and states want children to be immunized. We know that they want pregnant women to get prenatal care and postpartum care. But if I see a health plan has a population, let's say in Prince George's County, Maryland, where there is a high African American population, and if there's a lot of individuals that have sickle cell anemia, I want to know what programs and services are available for that population. The MCOs, the managed care organizations, really need to know what populations they're serving, and they can be unique. So we try to go beyond what is just required at the federal and state level to try to make sure that individuals are getting the services that are important to them. We also look at data trends. So having the experience of working with these plans from year to year, I know what their quote normal operations are. If there's a change in the if there's a change in staffing, a lot of times the new individuals don't understand what it is their expectations are with respect to the standards. So we look at what occurs year to year, and in that interview process, we do this whole review through a document review, desktop document review, and also interviews. And we use those interviews to further delve into what they're doing around a specific issue if we find that there might be some inadequacies in their approaches. But again, we focus on the strengths, and we always include the strengths in their final reports. Another aspect is that because there are 9 health plans, we have the opportunity to look at aggregate findings. So if we're seeing patterns across all of the health plans, whether they be positive or whether there are opportunities for improvement, we provide that information to the state to be aware. It may have us add a new standard. It may have us ask different questions based on what we're finding, but there's always an opportunity to look at things in the aggregate to try to make systemic improvements. And that's ultimately what we want to do, is to ensure the systems in place are user-friendly, that people have access to the services and supports they need, and that they have really positive outcomes. I think in reality, over the years, I think our findings and recommendations are really heeded. I think the health plans value our honesty and our experience across other states, so that we can help provide them other benchmarks, other successes and innovations in other states. And we give them that information, and they can use it however they want, but at least we know that we're trying to do the best we can to give them the best outcomes possible. So and the other thing that I think it's important to point out is that we make mistakes, and we're human. There's times that we have challenges to our findings, and that's okay. We are happy that the health plans feel comfortable doing that. We work together. As a matter of fact, last week I got notice that one of our findings, one of the health plans challenged one of our findings, and I went back through, I reviewed the information and provided an update to the state, and we work through this and try to come to some resolution that's agreeable to everyone involved. If we find that our findings are going to stick, then we support that with additional information so that the plans understand what it is they have to make improvements on. One of the things that we haven't really talked about much is there's the new bill is providing about $50 billion to rural healthcare systems by the year 2028. This is a huge access enhancement. So I think areas that we typically don't see good outcomes in rural areas, this is going to be a really promising improvement there. I think as a process improvement person, and I'm very big on reducing service duplication, streamlining processes, reducing the amount of paperwork people have to go through. And I think that there's a real potential here for, as the states and health plans have to revise or improve or basically get new information technology systems to track all the new changes in eligibility. I think that this might expedite some of the information technology systems that have lagged, in my experience, and ultimately reduce administrative burden and the outcome to care managers, providers, and enrollees who try to access services. So the other piece is the advent of artificial intelligence. And I think if it's used appropriately, and I emphasize appropriate use of artificial intelligence, may lead to some reduction and duplication of effort. Over the long term, I think data systems can be focused more on what the users need and not on what the systems provide. So if you have a software platform, we typically go, okay, what is the software platform capable of doing? We need to turn that language around and say, what is the user needing, not what the system can do. We need to have more user-friendly applications. And I think that if enrollees are involved in this transition to these new eligibility requirements, that having more input from them can really, really help reduce some of the barriers that they're facing. And we need to think about, let me back up a second on that whole concept of making things more user-friendly. If we can build in those exception criteria early on into the process, and instead of having to follow up with an enrollee over and over, if we can have information systems identify what those exemptions are early on and sort of screen people without having to do the follow-up, I think we can reduce a lot of the denials that happen with Medicaid applications and make that process a lot more user-friendly. And then lastly, right now, all of our evaluation systems, there's specific standards for Medicare, there's specific standards for Medicaid, there's specific standards around employee-based commercial health programs. And, I look at this as managed care processes are the same no matter what type of insurance program is there. In other words, there's always going to be quality oversight. There's always going to be utilization management. There's always going to be care management. There's always going to be outreach to enrollees and member services and provider relations. What's really unique is that the states understand the populations that are served. I think we can integrate many of these assessment parameters or evaluation standards and streamline them so that what's really important is that do we have a network of providers capable of serving long-term care or pediatrics or obstetrics? And then we also need to look at changing performance metrics to focus on those specific populations, but the rest of everything else is pretty much standard. So I think there's an opportunity there to really reevaluate how we're administering and monitoring and tracking and providing accountability to what's going on in the industry without making it so burdensome. Because right now, I think we have an amazingly administratively burdened system for all the stakeholders involved.